As we move on to the diagnosis and treatment planning in implants, the first and the foremost thing that is important is to record a proper diagnostic case history and then do a perfect clinical examination, both intraoral and extraoral. Then we obtained diagnostic impressions. With the help of the impressions, we obtain cast and we do diagnostic imaging, and with the help of surgeons and restorative dentists, we ensure that it is a collaborative work so that we are able to frame a unique treatment plan for the patient. Once the treatment plan is decided on, an informed consent is obtained from the patient. Do not forget to obtain or examine the proper medical and psychological assessment of patients. There are various imaging modalities as how it is mentioned in this slide, and these modalities can be divided into planar 2-dimensional, quasi 3-dimensional and 3-dimensional. Planar 2-dimensional includes periapical, bite-wing, occlusal and cephalometric imaging. Quasi 3-dimensional includes X-ray tomography and cross-sectional panoramic imaging techniques. 3-dimensional imaging includes computed tomography and magnetic resonance imaging, that is MRI. Implant imagings can be divided into three phases, phase 1, 2 and 3. 1 is done at the stage of pre-prosthetic implant imaging, 2 is surgical and interventional implant imaging, and 3 is post-prosthetic implant imaging. Pre-prosthetic implant imaging involves all past radiological examinations and new radiographic examinations to assist in final and comprehensive treatment plan. The objectives is to rule out presence of disease, to determine the quality of bone, the density of bone, to identify the relationship of anatomic structures, and to determine the ideal position for placement of implants. Periapical radiographs provide a high resolution planar imaging in a limited portion of the jaw, but the limitations are it is a 2-dimensional one and does not provide 3-dimensional information and is of little use while placement of implants. Periapical radiographs suffer from both distortion and magnification. Now, how good are periapical in terms of objectives for pre-prosthetic imaging? It is useful when we want to rule out any local disease or dental disease. However, it is of limited value in determining the quantity and quality of bone. It is also of certain extent important to identify the critical structures. In pre-prosthetic phase, periapical radiographs are often used for single tooth implants in regions of abundant bone width. Occlusal radiographs produce high-resolution planar imagings of the body of both the maxilla and the mandible. The placement of the film is made parallel to the occlusal plane, and for mandible it is perpendicular to the plane. For maxilla it is placed obliquely at 45-degree angulation. This is the picture which shows how the film is placed. However, it is of no quantitative use for implant dentistry. Mandibular occlusal radiographs seem to be less distorted, but however, it should be remembered that there can be oblique or distorted images and is of limited use in implant dentistry. Occlusal radiographs are rarely indicated for diagnostic pre-prosthetic phases in implant dentistry because it does not determine any spatial relationship with the associated anatomical structures. Cephalometric radiographs are nothing but the ones that are oriented planar radiographs of the skull. The skull is oriented with respect to the X-ray device and the image receptor using a cephalometer. The geometry of this imaging device results in 10% of magnification. Lateral cephalometric radiographs is produced with patients in the mid-sagittal plane. However, the uses of lateral cephalometrics are used while placing mandibular anterior implants or when we need to harvest this bone for ridge augmentation in the symphysis region. It can also be used when you need to find out a spatial relationship in the localized region. It can also be used for evaluating loss of vertical dimension. Skeletal arch interrelationship can be found out. Anterior implant crown ratio can be determined. Anterior tooth position in the prosthesis can be determined. This technique, however, is not useful for demonstrating the quality of bone. However, it can be recommended for placement of implants in completely edentulous patients. Panoramic radiograph is nothing but OPG. It is probably the most used diagnostic tool in implant dentistry. Though it is not the most diagnostic, it produces an image of the section of jaws of variable thickness and magnification. but however it produces non-uniform magnification. A 10% of vertical magnification and 20% of horizontal magnification is identified with this radiograph. The limitations are it does not demonstrate bone quality or quality or mineralization of the bone. It can be misleading because of magnification. It is of some use in demonstrating critical structures, and the dimensions of inclined structures cannot be relied upon with OPG. The advantages, however, are it can be used when opposing landmarks are easily identified. The vertical height of bone initially can be assessed with this. The procedure is performed with convenience, ease, and less cost compared to CT. CT is nothing but computer tomography. Is a digital and mathematical imaging technique that creates tomographic sections where the tomographic layer is not contaminated with blurred structures from adjacent anatomy. It enables differentiation and quantification of both hard and soft tissues. CT, which was invented by Sir Hounsfield, announced the imaging of this technique as early as in the year 1972. It produced images in various axial planes that are perpendicular to the long axis of the body. According to the Hounsfield's units, these values indicate the mineralization of different type of bone. Dentascan is the radiologist simply indicates the curvature of the mandibular or maxillary arch. With the help of this, the computer is programmed to generate reference cross sections, and tangential images of the alveolar bone are obtained with three-dimensional images. The cross section and panoramic images are spaced at between 1 mm distance and are very accurately used for pre-prosthetic treatment planning. The limitations, however, are the image may not be of true size and require compensation for magnification. Determination of bone quality requires use of imaging computers or workstations. Hard copy Dentascan image only include a limited range of diagnostic scale, and the tilt of the patient's head during examination is critical because all the cross-sectional images remain perpendicular to the axial imaging plane. ICT is interactive imaging tomography, which is addressed with which was developed to overcome the limitations of CT. The limitations of ICT are, however, the refinement and exact orientation of implant place might be cumbersome and difficult, and execution of the plan might be difficult. Coming on to magnetic resonance imaging, which uses the protons of the body by employing magnetic field radiofrequency, electromagnetic detectors, and computers. It is a three-dimensional imaging technique with an electronic image acquisition process and resultant digital imaging. It is used in implant imaging as a secondary technique when primary imaging techniques is used with ICT or CT. However, MRI is not useful in characterizing the bone mineralization or in identifying bone of dental disease.